we did an exploratory analysis of the ctDNA in the patients that were included in the IMvigor011. IMvigor011, just to remind what is this trial, is a trial that explored the use of ctDNA to drive the indication to administer adjuvant atezolizumab in patients with muscle-invasive after surgery having risk factors for recurrence. And this trial randomized patients to receive atezolizumab or placebo if they were ctDNA positive. If they were ctDNA negative, the patients were being followed. And another important thing is that the patients were included in the trial if at baseline the ctDNA was positive, but also these patients were followed throughout a year. And if at any point the ctDNA negative became positive, they were allowed to be included in the trial and being randomized, meaning we have like two populations of patients that have early ctDNA positivity and patients that develop later on positivity of ctDNA. And what we have been doing is an analysis to understand the natural history of the ctDNA and how this is impacting on prognosis. We plot the concentration of ctDNA with the timing, and what we see is that initially the majority of patients that recur, and recurrence is here based on ctDNA, it's happening in the first 6 months, and the concentration is high. Patients that recur later, after these 6 months, usually the concentration of ctDNA is low. And then we have translated these findings to see how is this impacting with the outcome. And we see in the outcomes, meaning correlating with the disease-free survival and overall survival, is patients that recur early, those patients are doing worse, meaning the DFS is shorter. If they are recurring later, they have much better outcome. However, at any time point, they are going to recur. Meaning that the best patients are the ones that maintain the ctDNA negative completely throughout all the study. And then we also did some additional tests, like correlating the ctDNA and the concentration and the timing based on the pathology. We know that, for example, patients with T2 disease, despite being T2, you need to check the ctDNA. We have seen patients that have high ctDNA concentration, and those are the patients that might recur and progress. And then after describing the natural history of the ctDNA, the timing and concentration, and timing stands for the early versus late, we move to the dynamics, how the ctDNA evolves while the patients are receiving treatment with atezolizumab. And we saw that atezolizumab is able to make a decrease in the ctDNA compared with placebo, and the decrease is really a deep decrease. There are some patients that if you are able just to decrease the ctDNA, these patients have much better outcome, meaning that there is a correlation between the decline on the ctDNA while the patients are receiving atezolizumab with disease-free survival and also overall survival. The value of the ctDNA in patients with placebo. Interestingly, we saw that some patients that have minimally positive ctDNA, they do well because it disappears, meaning there is a specific population of patients that maybe they have very low levels of ctDNA, and those have a test in the beginning that is positive, but then completely disappear. This is a new finding. We don't know if there is immune system that is killing this early release of ctDNA, but yeah, those we present the results on both, on the treated patient population and also in the placebo-treated population. So in conclusion, atezolizumab is able just to decrease and to make a deep decrease on the ctDNA, and this correlates with disease-free survival. ctDNA is helping to predict, based on the timing and the concentration, the prognosis of the patient. So it's a tool that can be used just to say, well, this patient maybe now we need to think on designing treatments that are much more stronger just to overcome the limitations that is giving monotherapy with atezolizumab. But in fact, yeah, the IMvigor011 is the only trial that is showing that doing this selection, giving atezolizumab in patients who are ctDNA positive, is translating on disease-free survival and overall survival. The others, the pembrolizumab and nivolumab, we see benefit in disease-free survival, but still the overall survival has not happened. Meaning selecting patients based on ctDNA is a way to optimize the treatment in these patients and get results positive.
was asked to speak on the two abstracts that were presented before me on the first session at ASCO GU this year. Those abstracts looked at the role of hormone therapy concurrent with postoperative radiation and the use of brachytherapy as a way of dose escalating radiation for high-risk disease. Radiation for prostate cancer is part of a multidisciplinary strategy. We work together with medical oncology and urology to figure out the best approach for each patient. And I think patients often come in really misunderstanding what the value of radiation and what it can offer. So I think in that room, I wanted to level set that radiation really works very well for prostate cancer. And that was my first discussion point, is that we have excellent outcomes even for very aggressive disease. And then the main point of the rest of the talk was really focusing on how do we apply the data that was presented to our patients immediately in front of us now, and how do we tweak both making sure we have great cancer outcomes? Are we curing patients? Are we giving the longest opportunity for disease-free intervals, but at the same time being thoughtful about quality of life so that we're not over-treating them either? It's really a Goldilocks approach. We don't want to undertreat, but we also don't want to overtreat. So the first abstract that was the POSEIDON analysis by Dr. Marquishan et al. And that specifically took 4 large, very well-respected trials in the postoperative space that evaluated the use of hormone therapy with concurrent radiation. And the challenge with those trials was that each trial really was felt to be probably underpowered for a survival benefit. And looking at earlier benefits like PSA progression can be challenging because with hormone therapy, you can get a suppression of PSA even if you actually have no change in the actual cancer biology or function, but you just sort of get a temporary hold, a pause. And so looking at early outcomes like that can be a little misleading as to whether there's actually a difference in cancer outcomes, death from prostate cancer, overall survival. So that's why they looked at an overall survival endpoint, and to get more power, they pulled all those studies together. What was really impactful is, there's an ongoing debate and actually every week when I take care of patients with my medical oncologist, we say, okay, does this patient need hormone therapy? How much hormone therapy? What's the right story? And so this was really helpful in saying, look, now that we've looked at all the data and we put it in one analysis, it really stands up to say that patients with sort of lower aggressivity, so lower PSAs, probably, the less aggressive Gleason scores really don't need hormone therapy. Radiation works very well in those patients. When we get into the more aggressive biologies, that's when hormone therapy can benefit. The other key takeaway on the POSEIDON analysis was that most patients do not need more than 6 months. Even if you need hormones, you don't need more than 6 months of hormones. And that's great news for patients because 6 months usually they can recover very well from. When you start to give patients a year, 18 months, then many men don't ever get their testosterone back. And so that's actually very exciting for patients. The second study that I discussed was the ASCENDE-RT study. And this was a long-term follow-up, 15-year follow-up on patients that were either randomized to either radiation alone or external radiation alone, or radiation with a brachytherapy boost, which is a way of giving a little extra radiation dose. And the idea was that the hypothesis was that brachytherapy boost would be more likely to eradicate disease in the prostate, which would ultimately provide a better survival for those patients. The reason that it was a debate is that brachytherapy, because it's such a much higher dose, can also have some increased toxicity, particularly urinary toxicity, can damage the urethra, things like that. So that was why we really cared about the results of that study. And what it showed is, while it does perhaps have some benefit in around like the prostate cancer cause of death, so maybe a little less likely to die from prostate cancer, there was no difference overall. So really kind of, I think, was a little bit of a dampener around the use of brachytherapy. But I pulled some data from other studies and kind of correlated that there, again, probably is still a role, but it really needs to be focused on the high-risk patients where we think that disease in the prostate specifically is what's going to drive their overall outcome. patients that are high risk of nodal disease or metastatic disease probably don't need brachytherapy boost. They really need to be focusing on local control, but all systemic disease. And then the folks who really just have aggressive disease only in the prostate, those folks, particularly if they're going to live a long time, those are the ones who really will benefit. Very excited at a later session here at ASCO GU. There was some really nice talks about upcoming therapeutic options, systemic therapeutic options. I'm really excited about T-cell engagers. The question about will it impact sort of radiation sensitivity, we don't know yet how that works. I think that there's a really interesting interplay for prostate cancer and our immune systems. And traditionally, we have felt that a prostate cancer is sort of a immunodepleted cancer. We don't really get a lot of immune response when we treat, and it seems to be masked from our immune system very well. It's probably why it's such a prevalent cancer. Radiation works in part by stimulating the immune system to attack these cancer cells as they start to die and perhaps present antigens that then can be that our immune system can use to attack. So anything that's whether it's CAR T, whether it's T-cell engagers, and really where we're headed in the other agents, I think that may have a very exciting benefit on the radiosensitization. It's still early days because right now they're looking at advanced disease, and it'll be a while till we're ready to look at combination drug plus radiation.
Frailty, very briefly, is a multi-domain assessment of vulnerability to stressors. People who have a high burden of frailty do not respond as well to therapies. They cannot tolerate therapies as well. This has implications for treatment tolerability. This has implications for oncologic outcomes across cancers. There's an ever-increasing body of evidence that I would say underscores the importance of how frailty is something that we all need to be very aware of as healthcare providers, as physicians and surgeons. Patients with genitourinary cancers are overwhelmingly older. They have a high burden of comorbidities. They have a high burden of frailty. And it's something that is not commonly assessed in routine clinical practice. So the program committee identified that this is something that there's this emerging body of evidence that really says we need to be measuring this in our patients. Importantly, a lot of our guidelines actually say that all of our patients, before you make a treatment decision, you should assess them with a geriatric screening tool or a frailty assessment to inform whether more testing is needed and also to help select treatments that are likely to be well tolerated, more likely to be able to be administered, and ultimately to get patients the best oncologic outcome that one can. And there's this really strong push, obviously, to ensure that we are always participating in shared decision-making. That means we need to educate patients about the disease and make sure that they're understanding sort of the ramifications of the treatments they choose. But at the heart of that is priority elicitation and understanding what's important to patients. And that's kind of a principle of geriatric care, geriatric medicine. The real goal here was, can we take all of these optimal components of how we should be providing care to our older and more vulnerable patients, which honestly is actually a very large swath of the populations we treat. Can we start to educate everyone here at ASCO GU about how we can do this well, how we can implement these procedures in practice, how we can make it easy. What does it all mean? What are the ramifications of it? And have a real conversation around sort of leveraging these principles of geriatric medicine and geriatric oncology and learning these lessons and bringing them into our clinical practice. So basically, we had an hour-long discussion trying to touch on a lot of these key themes. And it was a really robust, great panel discussion. Covered, Dr. Kandambi gave a wonderful just masterclass in understanding frailty and geriatric assessments. I got to talk a little bit about the work that we've been doing at the University of Washington around Once you have assessed frailty, how do you understand what's driving the frailty, and then how do you start to fix those problems through what we call prehabilitation and rehabilitation. And then we also had Dr. Cordes, who's a pharmacist, and she gave a really thoughtful explanation of the complexities of pharmacokinetics and the metabolism of a lot of these drugs in our older patient populations. And then Dr. Hannah Hunter is a physical medicine and rehabilitation specialist. And so she got into some of the physical assessments that she and her colleagues use. So we tried to hit a lot of topics really quickly, but it was just a great, great discussion. So the first is that frailty is really prevalent, but if you don't look for it, you probably won't find it. You won't notice it. So that's where it's just really important when you're assessing patients to try to use objective tests to understand this balance of vulnerability and robustness. But it can't just be an assessment of the binary. It's not frail, not frail, because that actually is not terribly helpful. That kind of goes back to the eyeball test, fit, not fit. That doesn't, it's a very subjective assessment. You can't really reproduce that. It's hard to teach. It's not something that we could introduce into a clinical trial structure as an eligibility criteria. But if you use a geriatric assessment tool, of which there are many that you can easily implement in practice, you can start to understand, you can essentially use objective numbers to score patients. And then you start to understand, like, what domain is actually causing this person to be more vulnerable? Is it that they're malnourished? Is it that they're not physically fit and strong and they have balance issues and they're a fall risk? Is it that they have so many comorbidities that the burden of all those comorbidities is actually making them feel worse or making them more vulnerable? Is it that they're taking so many medications that they're interacting in such a way that it's really dangerous? So I gave an example of a case of a lady who actually was falling as I was trying to get her ready for treatment of her upper tract urothelial carcinoma. And it turned out she was over-treated for her hypertension. And once we got her meds sorted out, she was normotensive and stopped falling and stopped winding up in the emergency room. And we were able to essentially optimize her for her surgery. So 1, look for frailty. 2, measure it. Don't just say it's there, it's not there, and measure what's driving it. And I spend a lot of time studying how exercise should be implemented as part of comprehensive cancer care. So then we got into a discussion of why exercise is important. We talked about the benefits of exercise for our patients with cancer. We talked about the fact that it's not just meeting the American Society for American College of Sports Medicine's recommendations for 150 minutes a week, which I asked the audience how many of us are getting that. And unfortunately, it's a lot. Not even many healthy American adults do not hit those marks. Our patients with cancer, definitely about a third of them are actually inactive based on survey studies. So, but what we know is that even a little bit of activity is beneficial. And those patients who are really inactive, those modest gains in activity have tremendous benefit. So we got into the data, for example, from the Challenge trial, which was a randomized controlled trial of structured exercise versus just giving someone information that they should exercise more, or health education. And that was done in a colorectal cancer patient population. And we showed not only the potential benefits in terms of improving activity and physical fitness, but I think what was the reason that trial is a New England Journal publication and is something that every oncologist should be aware of, is they demonstrated a disease-specific survival and an overall survival benefit with the exercise. And it was also very safe. There were very few adverse events. And then I highlighted a few of the trials that we're doing at the Hutch, specifically looking at exercise in the perioperative space and in the survivorship space. So the take-home point was, or I would say one of the most important take-home point is that we should all be aware that exercise is part of cancer care. We can help patients exercise as oncology physicians by telling them that it's important.